Let's talk about using technology to address social determinants of health in rural communities. And to talk about this, I'm really glad to have with us Derek Landis. And Derek is a social worker. He's also the telehealth coordinator at Missouri Rural Health Association. And he is focused on increasing health equity. So yeah, Derek, thanks a lot for joining me.
Absolutely. Glad to be here.
Yeah. So one way I like to get started is to get a sense of what brought you into this field. So what got you interested in helping with rural health and social determinants of access to treatment, et cetera.
Yeah, I mean, I think like a lot of us, it's because it's personal. I grew up in a small town, and I witnessed the impacts of there being a lack of healthcare. Specifically for me, it was having a lot to do with the friends I had growing up, and watching the opioid epidemic have an impact on people I cared a lot about. And it's hard to watch and not do something. And so, I initially started as a substance abuse counselor, and I was working with guys coming off opiates. And it slowly kind of built from there. I went, okay, well, what can we do for the community? And so I started working on a community level and did that for a while. And then went, okay, well, there's a lot of stuff that we're trying that's not working. Why is that? And I got involved in research and ended up working on my first couple papers, which led to me doing my MSW and starting to look at, okay, so what can we do across our state to better increase access?
Yeah, so you started off with like getting in there, actually providing services, and then got interested in, well, like how effective are we being and how can we improve this? How can we improve the system? Yeah.
Because I mean, I think if you're involved with it on any level, you start to realize there's just not enough. There's not enough boots on the ground to handle what's going on, and we got to figure out what we're going to do about that.
Yeah. And so when looking at rural health, what's unique about rural health or rural communities in terms of social determinants of health? Like what's the difference between someone that lives in a rural community versus someone in a community?
So we can look at outcomes is a good way, I think, to start that. The reality is on pretty much any health outcome, the metrics look worse. Shorter life expectancy, increased disability, increased poverty, worse outcomes, higher rates of death for every leading cause of death. All of this gets worse when we look at the intersection of any minority group in rural as well, where we see numbers start to get really, really rough. But just in general, our rural communities tend to be less served.
And what I find interesting about this is my being naive or ignorant about a lot of this. So when I think about rural communities, I think about like close communities, your neighbors, people watch out for each other, maybe a little bit slower pace. You might be eating healthier, more farm to table kind of thing, less pollution. So it seems like there'd be some positive determinants of health in rural communities versus negative. But I hear what you're saying is that when you look at the outcomes, it's actually the opposite. Their outcomes are worse across the board.
Yeah, and you bring up pollution. If we look at social determinants of health, the one area we score better is in air quality. Besides that, nutrition, addiction, obesity, everything, lack of education, all of those other determinants are higher. In general, our rural communities are older, poorer, and sicker.
Yeah. So what are some of the barriers or biggest needs then of rural communities for healthcare?
It's a complicated problem. Is what we're seeing right now is, at least in Missouri, I can't speak for the entire U.S. My focus is on the state, and I'm really looking at what's going on out here, and that's why I got involved in what I did, because a lot of what we saw was information from other states, and that didn't necessarily make sense for us. So, I mean, I think the first thing we got to look at, okay, what's specific to me and our community, but there are geographic barriers are, of course, massive when we're looking at the time it takes to reach a facility that's significantly higher. And you don't necessarily think about that, but that plays out in a lot more than just an emergency situation. Sure, that's huge. That's critical. I mean, we're talking about something like a heart attack. The time to hospital is a big deal. And if we're driving 60, 90 minutes to pick up a client and then 60, 90 minutes back, that's a long time before you reach the hospital with something really serious. But then that plays out to everything. So somebody's going through chemo or on dialysis, and you got to figure out, how am I going to get to the services I need to receive? And this isn't a, how do I carve out an hour out of my day? This is, how do I carve a day, sometimes 2 days out of my week, so that I can get there, figure out a hotel, stay, plan for transportation. And if you lack transportation, then this is extremely difficult. Or if you have transportation, I grew up in a spot where I knew a lot of people who had a truck, but you didn't take that truck on the highway. That truck was for getting around the farm. And so how do we get there and reach that service? That becomes brutal. I mean, growing up with my grandparents, it was, let's drive out to Kansas City. It's the biggest city. And that was a 2-day event every week that they had to take off of work and everything they were doing.
Yeah. So in terms of social determinants, you have older population, more poverty, not as high quality education, barriers to access to healthcare.
Yeah.
Just there not being providers or specialists, or the level of care needed in the geographical area.
Mm-hmm.
Yeah. So
and we're
it does. So you mentioned it's complicated. It does. Seems like it's multi-factored.
Yeah.
So there's like, how do you stay healthy in the first place? And then if you do have illness, disease, getting treatment. So
Right.
It's okay. Yeah.
Yeah. And we're seeing the problem get worse right now, not better overall. And that's a part of it, is that we're experiencing provider atrophy. If we look at our stats. So, 50 years ago, small town, there's a bright kid, you send him off to school, kid gets a medical degree, comes back to the town doctor until they retire. That doesn't happen anymore. That's not how people go through training and education. There's a lot more steps in residency, and people are moving around and doing different things. So we're not seeing the traditional way of getting people back into the community to provide service. A lot of providers we're seeing them leave their communities because there's higher income value in a urban area, or that they come out because there's a program and it's good to get them started for a few years, but then they leave. And we're seeing hospital closures. And as hospitals shut down, those have massive ripple effects across an entire region, entire areas. And we've seen closures every year, almost.
So in terms of rural communities, what about communities like the Amish or Mennonite communities, where they are more kind of a rural type of community, but it seems like they have really good health, like they're active and I mean, is there anything to be said about that? Or
I mean, that's a kind of a different area. I've done a little bit of work in that. I was working with a nonprofit at some point that was looking at barter system medicine with the Amish communities. We do have Amish communities out here. You drive down our highway and you'll see wagon crossing signs, and they're figuring out stuff like how many doctors visits equates to how many roofing jobs around town, and how can the town pool income, and trying to figure out how to build collaborative relationships, because there's still a need of, what do you do when you have a chronic condition? What do you do when you get hurt bad? What do you do when you get old? What do you do if you type 1 diabetic?
Yeah. So now this has led me to the thought of, we're going to be talking about how to use technology to address social determinants, but like the Amish and Mennonite communities, they use very little technology. But and again, I don't know what the statistics are, but they seem to be a fairly healthy community. So yeah, it just anyway, it's a thought that came to my mind, and in terms of what's to be learned there from those communities. Yeah,
it's complicated. You're right. It comes down to how does technology, at least my job, right? What I'm looking at, how does technology help bridge that gap?
Mhm.
And in which ways can that work? So what problems do we have, and how many birds can we hit with one stone? And I think that's really important when we're trying to tackle a problem without a lot of resources to do so. Because another piece of that puzzle is, you know, at least in our state, if you watch funding trends, of course they're going to the larger metropolitan areas. Population wise, rural accounts for a lot, but Kansas, you know, the big cities make big blocks, and those are really important when it comes to policy time and voting. And so we see a lot less funding for projects. Okay, we're going to take the funding we can get, a lot of times through like the Department of Health, Department of Senior Services, maybe through USDA, and go, okay, so multifaceted. Okay, how can we help rehab an old building while at the same time turning that into a facility that can bring in providers in a way to provide specialty care that we couldn't access there, and integrate that with already existing hospital systems to help them become more profitable, because they're going to be able to provide more service lines by connecting all of these things, as well as, you know, how do we increase prognosis, you know, to not have to have someone show up to the hospital and be airlifted away to a different hospital. Them staying is both increased revenue for the hospital, increased prognosis for the client, because it's easier to do follow-up care. We don't have to move them, especially with something severe. So how can we, there's a lot of ideas we've been playing with, and that's kind of what we're testing right now, and in a way that specifically puts resources back in. We want to support our rural communities to help them grow. And that gets over another barrier of when we're talking about there's a mistrust of we're going to put something in place that's going to hurt our community. It's going to take something away.
Oh, okay. Yeah, like take business away, take revenue away.
You know, the community's hospital is usually a major employer. They serve multiple counties around. A city loses their hospital, a large percentage of the town loses their job. So how are we going to support that community so it can grow, so it can take care of the people there? Because I think it's important to note here for anybody with an urban perspective, you know, you're from a metropolitan area, you're trying to think about this. There's a systematic thing here we have to think about, because rural provides our base resources for everything. You know, this is where our clean water, our energy, our food, our resource, all of the base resources that make the city work come out of rural. And as those communities experience atrophy, as those communities shrink, as those communities die, that has repercussions beyond that community. That's going to impact the metropolitan areas that do rely on them for all of that.
Right. Yeah. So it's using technology to leverage the resources that you have, which are the providers that you do have in rural areas, which is very limited. The hospitals, the healthcare facilities, which are limited, but leveraging what you do have there, and then leveraging the funding that you can get from government organizations, and leveraging in a way where it's not going to be pulling funds away from you know, established facilities in rural areas, but supporting them. And then in terms of the coordination, it sounds like a big part of what you do is linking organizations together and linking providers with resources, because they may not know about what's going on out there, what's working in other rural communities, and so forth. You kind of have like I would imagine a bigger picture. You're kind of looking at the area as a whole rather than one facility.
Yeah. Well, and because what you're hitting on is isolation's a problem. I mean, this is a big problem. Not just on connection and solving other issues, but I mean, there's a reason why one of the highest suicide rates is amongst farmers. I mean, the isolation is difficult.
Wow.
We're social creatures. I mean, the state of Missouri recently released a suicide prevention hotline specifically for our farming community, because we needed to figure out how to address how bad that's getting.
Yeah, you know what's interesting about that too? You hear that how good gardening is for mental health. But gardening is different than, I guess, being a farmer with all the stresses where that's your livelihood and you're isolated. It's what you do. It's a way of life. It's right. And it's a hard way of life. Very hard life.
It takes a lot of work. But that isolation, I mean, and across the board, I'm removed from opportunities, from a lot. But the point was connecting providers. You think about your large areas, your information hubs, your education centers. For us, that's Columbia, the University of Missouri. The University Hospital is a really good place for providers to grow. We have this hub where doctors that are interacting with that, connecting with the university, the newest research, the newest ideas, and there's a reason that is really important for the state, for that community. But how can we facilitate that? All happens because of connection, because of people being able to share ideas, be able to explore new ideas. And that's an extreme example, but in general, how can we get everybody at the table? We don't have the same opportunity for, all right, we'll have a golf club that everyone can go to once a month, like you might in a city, and connect and have a networking event and, bringing all that together, brainstorming sessions. That's hard to do when people are 6-7 hours apart and already overworked and working, wearing multiple hats, because, if you're the town's only MD, you're not a primary care provider. You're a primary care provider. You're an OBGYN. You're doing everything.
Right.
So where could we create and house that? And I think that that's an opportunity for technology, especially as people become more comfortable with social media networking. One project that I've been working on, and it's still really new, and I think we have a long way to go and several years on it, but it's creating that space where everybody can interact and share information and share resources using technology to bridge that for our members.
Right. Yeah. Having quick, easy, accurate, access to resources, information is key. So if you have a particular issue, being able to find a specialist that's available. Yeah. All
the echoes. I don't know if you have echoes.
Oh yeah. The Echoes project. Yeah, certainly.
The Echo project's been phenomenal too. I love getting on those echoes. I go to several. Those are, I think.
Yeah.
But it brings up another thought for me, at least, is we're talking about tools, and I think that we had a lot of problems to fix, and a lot of different problems require different tools. And I think Echo is a tool, and I think community platforms are a tool, and provider-to-provider telehealth is a tool, and they're all just different ways we can help look at different problems to create the best win-win-win for everyone.
Right. Yep. So, use technology for early detection, for finding access to care, to getting follow-up care, and getting education to those with struggling with illness. Can you share some success stories of how implementing technology has addressed some social determinants to health in rural communities?
One of the projects we're in the middle of right now, I'm really proud of, and we got some grant funding, and we partnered with 6 hospitals across the state to pilot bringing a VEL, which is a telehealth provider, into our rural hospitals. And I think that has been challenging, and there's been a lot of hurdles to overcome, both regulatory, socially, and just technologically. But to be able to integrate some of these services into the hospitals has been amazing. And what I liked about working with a VEL, and I mean, I sound like I'm doing an ad for them, but I've been really pleased, is they understand rural. They understand the specific needs in rural, and they also understand investment in that community, and have created a way in which integrating healthcare it doesn't feel like the big city doctor showing up to take over what you're doing. And that's sometimes what it feels like to people. This feels like we're partners, that we're here to help, that it has been coming in to provide supplemental resources to not step on people's toes in a way that the hospital can bill for. Because we integrate this, the providers are getting their state licensure. We're getting them registered with the hospital. The hospital can bill for those extended services and just pay a flat fee.
Oh, so the actual clinicians will get paneled through the local hospital, the local facility, correct, so that the local facility will be doing the billing, but then paying Avel a fee,
a subscription, like you might do with Netflix or something like that.
Sure.
And part of the test in that, where we come in is go, okay, how do we organize it so everybody can work together? the biggest cost barrier is getting a program like this started. Grant funding for a program like this doesn't last for 20 years. We got 3 years. We're going to pay for this much of it year 1, this much of it year 2, this much of it year 3. So by the end, it's self-sufficient and pays for itself.
Okay.
Look at, and because we've been able to increase these service lines, they think some of it has benefits beyond that you don't necessarily see. Workforce recruitment and retention is a really big issue. I'm working with a hospital right now who has had they have one MD. So he's been on call 24/7, 365.
And what happens when that MD resigns?
Yeah. And now he can sleep for 8 hours a night because the nurse can press a button and get an MD. In one of our other communities, we've had a huge mental health crisis, and we can press a button and get a behavioral psych nurse to do an assessment and to be able to help now start getting that referral to an appropriate service and be able to move through that access point. And that helps HPSA scores, that helps with a lot of other factors in maintaining this hospital. And then specialty care. We're not going to ever be able to we're going to have a full-time cardiologist in a really small community where that doesn't come up every day. But if we're working with a company like this, you can go, we'll press a button and the cardiologist is there when we need it. So now that specialist can be brought in to supplement the boots on the ground.
Yeah. And for one hospital to try to coordinate, try to establish this with Avell would be quite a challenge, it sounds like. But through the Rural Health Association, bringing together, 6 different hospitals, getting the funding, making it worthwhile for all of the, front end work that goes into it. It sounds like that coordination that you all are doing makes this possible.
There's a lot of pieces that to be able to go through. To make the argument, here's how it's going to help design it in a way that supplements and that the project's going to last, and bringing everyone together that makes a much stronger grant application. When we're looking at a bigger impact, to cover those initial costs, like we were talking about, there's a lot of pieces to it. And then figuring out how to make all of them work together and then spread out to other places.
Yeah, that's a great success story, especially the financial piece, because I know the financial piece is often a great challenge, where if money is just going out to this telehealth service provider, it makes it very challenging for the local providers. And then, is it sustainable? Is there really buy-in? Or are they just gonna, when it's not financially successful or whatever, better, then they might just
last thing you want is your rural hospital be going, okay, this is great, I can provide more services now, but now I'm going to shut down because because I'm losing all my census and my, we're not, the goal of most rural hospitals, they're different. We're talking about rural health clinics, we're talking about critical access hospitals that we're working with. This is different than hospitals that have profit margins. They don't. We're trying to get to zero. And most of them are operating in the red across the state. They're not making money. We need to get them to zero. And so figuring out how to implement really large programs is hard when there's not excess money. That just doesn't exist.
Right. Yeah. So you have to have a good plan and incentives for a good telehealth service provider like Avell to partner with hospitals in a rural community.
Yeah. Well, and you think about it this way, it's also, people are busy. Especially these last few years, our hospitals haven't had an abundance of labor. There's been a massive shortage. We're short on every level. We need more nurses, we need more MDs, we need more administrators, we need more, at every position, we need to fill it. So going, okay, let's just find someone to dedicate extra time to outside projects that might help stuff grow isn't always the most viable when you're going, we need all hands on deck to keep the ship rolling.
Yeah. So Avell brought a whole lot of providers. Is that right? And are they employees or contractors?
So they're employed with Avell, and Avell operates, in my head at least, is a kind of a virtual hospital. Their MDs aren't necessarily ever bedside.
Right.
They're working with a lot of rural regions with using technology so that button's pressed and they're immediately in the emergency department.
Yep.
In a rural area, or they're brought in on an iPad and a cart in a hospitalist program to help do rounds, to help cover or it's the nurses. Sometimes it's little things that make a big difference. The nurses press the button and they're able to do triage while a Vel nurse is doing the chart. And so they're able to be more efficient and taking care of what's going on to get to get backup.
Yeah. So they're employees of a Vel, but they still get paneled through the local hospitals as a clinician with that hospital.
And that was a really big part of the project for us. That process of getting them credentialed.
Yeah.
That took us a year. That wasn't a short ordeal. And so when you're trying to get a company to come in and go, we're going to do this, I think that's part of why you need to organize multiple communities together, because there's a huge investment on the front end to go, okay, we're getting all these providers. It's going to take a year of work.
Yeah.
We need to be able to have enough skin in the game that it's going to be worth it for them to come in.
Sure. And what about any other example of other social determinants of health? Because the Avel that addresses access to specialists, access to healthcare. What about other social determinants of health and how technology could be used?
So there's, I think, a lot of different tools, and what's fun to me is we're going to see them play out over the next decade. I think a lot about digital health monitoring and what that can do for the rural patient dealing with a chronic condition, where we can reduce how many visits can we just say you don't have to come in. I got your data from the rural tracking. We can just do a phone call. That 5-minute follow up. We can just do that because I have the data.
Right.
I think that's huge. I think for services that are complicated, for my background is, like I said, I worked with substance abuse as a counselor first. Access to mental health. I don't think we can train enough mental health providers right now to meet needs. Logistically, I'm not sure that's going to happen. And so being, especially for anything where we see that intersection, like we were talking about earlier, I spent a long time working with sexual health, with HIV in rural, and looking at specifically how we're going to deal with that, because we've seen HIV go up dramatically. But stuff like pharmacy, being able to use technology for pharmaceutical, we've looked at maybe doing with Avel a pharmaceutical program to help some hospitals with that. But access to medicine is huge through tech. Being able to get specifically mental health services, I think, is going to be a big difference. Being able to get inclusive healthcare when necessary, LGBT mental health inclusive counselors are hard to find in your town of 500.
Yeah, especially in a rural community, if the rural community is not open or accepting to that, and then when people in your community, and this lack of privacy in receiving services in a small community.
Yeah, that I'll speak from the provider perspective. When I was working in mental health, it's hard when you live in a small town. It's really hard to be the one mental health provider because there is no off time. How do you go to the grocery store?
Yeah.
How do you go to the mechanic?
Oh yeah. Yeah.
And I had to move. I had to move a town over just so I could be separated.
Wow.
And that was really hard. I had extra commute and time and cost and all of that.
Yeah.
Just to have some anonymity. And so that's part of the recruitment and retention struggle.
Yeah, that makes sense. Yeah. Well, this has been really helpful. And really appreciate the work that you're doing on this. You're definitely making a change and impact. Sounds like there's a lot more, like there's always going to be a lot of work to do in this area. So you're trying to identify like what tools work really well. And that's the important thing about these interviews that we do, is letting people know what has worked. So because there's a lot of, you see a lot of offers from technology providers and so forth, and you're like, well, does it actually work? Does it actually make a difference? So you want to hear from someone who's been there, done that, that's used it and it's been successful for them. So hearing from you what's worked is really helpful. So that's one thing I've really enjoyed about the telehealth community is people sharing ideas and sharing their experiences, because everyone that works in this field knows how hard it is to vet out, service providers and technology. You really want to know kind of from someone that's really experienced it and got into it, before going through all the time and effort and commitment to partner up with the provider.
Yeah. I think, if we want to talk about barrier solution, I think that's a great quick segue into why we've seen a lot of hesitancy in our rural communities too at points has been because everybody's been waiting to see how it plays out on the legal level.
Oh, right. Yes.
And not that uncertainty I have seen have an impact. Are we going to be able to do audio only, which is huge in rural?
Yeah. And just to clarify, what you mean is whether or not insurance companies will pay for the service. So will Medicare pay for audio only? Will Medicaid pay for audio only? Or will they pay for asynchronous treatment where you're, reviewing files and giving recommendations, so forth? Yeah.
And for anyone that's watching, at least from what I've seen, and a big part of my job is tracking policy and looking at how that policy is going to impact, sure, we got extended again, but it looks like a lot of what's in the current bills are going to pass. We're going to see a lot of stuff get solidified. I think they're just going to take a little bit more time with it. But I think what everybody's saying on those levels is we're going to see it looked like it's had a positive impact. We're going to see some of that stuff set in stone, but it's going to take some time.
I sure hope so. Because there's providers that do telehealth really well, very ethically, legally, and so forth, and have great outcomes. And then there's some bad apples.
Sure.
Yeah, that abuse, abuse any kind of abuse things whatever way they can for financial gain that really gives the field makes people worrisome about reimbursing for more telehealth type services. So it's the regulation piece has to come along with providing access or reimbursement for services.
The other big win, we're talking about wins, is the broadband infrastructure stuff coming down from feds is going to make a difference. It's going to take a long time, and that's frustrating because we have need right now. But we talk about some of these great solutions. We had Evel set up in one of our hospitals, but couldn't turn it on for 6 months because we didn't have the broadband capacity yet. So getting that broadband set up is critical to everything we want to do on the tech side.
Seems really critical. It seems like that will be a real game changer, not just for, say, access to healthcare, but just education, opportunities for jobs, all of that. Seems like it would, you talk about being connected to others socially.
Sure. I think an organization like ours can only really exist in the at least in our capacity in the technological era. For us to be able to have staff across the state that are seeing what's going on in the different rural regions, that that we're able to coordinate and work together using remote technology.
Right.
If we had to do that all over the phone or driving multiple hours every week to see each other in person, that would really slow down the efforts. But to be able to collaborate using tech is a massive part of this.
And then I guess having contingency plans. So when technology is working, when you have connectivity, you can get certain services. When it's not working, you're going to need brick and mortar places to actually go to physically to get services. But then when you can't go to brick and mortar, you're going to need the online services. They're a backup. They're a contingency for each other.
And I think this is important to talk about and think about it. I go back to, it's a tool. And telehealth, I love it. I'm the telehealth guy, right? I'm all tech all day, but it's never going to replace boots on the ground. We still have to have you need a primary care provider in communities. You need somebody who can interpret what the specialist is doing. You need somebody, who's embedded, that's invested in the healthcare of their clients there. You need a hospital. You need an emergency service department. You need a place where you can go and receive cancer treatments and dialysis and anything else. But technology is a tool we can use to supplement all of those things to help both of them grow. And I think that the best way for us to look at technology is in how do we make this a win-win for our communities, where everybody is getting better results, we're increasing prognosis, everybody's being able to everyone's able to profit from it, right? I mean, that's equity,
right?
And looking at using technology for the purpose of creating health equity in our rural communities is to make a job.
Yeah, and I really like how you mentioned the fact of having healthy rural communities has an impact on urban communities.
Yeah,
like you're saying, that's where we get our water, our food,
lumber, electricity. I mean, everything.
Right. Yeah. It's a great point. Yeah. Well, thank you very much, Derek. This has been very helpful. And again, really appreciate all the work that you do.
Absolutely. Glad to meet. Thanks for having me, and feel free to reach out anytime.
Yep, you got it.
Have a great day.